Hello, Professor Takehiro. Takehiro, can
Yes,
you?
nice to
Yes,
meet you.
nice to meet you. I can hear you well, and you
Mhm.
are the last speaker. So, would you like to
Yes,
test your
that's right.
presentation? Would you like to test your presentation?
Yes,
Yeah, you may test now.
I'll share
Yeah, please.
with you.
Yeah.
All
Great.
right. Just a moment, please.
Good. It's coming.
Can you see my slide?
Mm-hmm. I can't. It's still running.
Can you see my screen?
It's running, but not come out yet. It shows that you already start sharing, but from my end, I can't see. Actually, I use two devices.
Yes.
And still running. Would you like to stop first, then try again? Seems it's still running, but I don't know why. It looks freezing.
Yes, maybe it's
Yeah, please.
not running.
Yeah, not running. Actually, it's it almost freeze because it shows you already start sharing, but for some reason, it's nothing come out. And yeah, would you like to stop sharing and try again? Maybe something not a bit right now.
你能够把它停掉吗？停掉，它再重新再 loading 看看。
Let me try. Maybe I can.
Looks freezing.
Yeah, your screen is freezing, and I'm going to try
Okay.
whether I can stop your sharing. And okay, maybe. Okay, you start. And would you please try again, so that we can make sure everything is okay. Oh, 他离开了，奇怪了。
他应该再去试看看了。
对，他刚才那个有点，
loading
他好像他声音我刚开听的有点抖抖的，觉得他那个频宽有点问题。Hi, Dr. Panipa.
Good morning.
Good to see you. Yeah, good to see you again. Yeah, you're okay. You already test your presentation yet. Would you like to try again? If you like, you may try again. If
Yes,
not,
so
it's okay.
if I can.
Yeah, sure, please. Yeah.
Okay, so where is my slide?
Definitely your slide here.
Yeah, so just a little
Okay.
at the moment.
Sure, no problem.
What? Okay, so
Your presentation, yep, yes, I see it. And
okay, so I think I will not go through other slide because we already tested yesterday.
Yes, yeah, you may stop sharing, and thank you very much. So you may take a break and come back just a few minutes before session start. Thank you, and mute your microphone and stop sharing. Hello. Doctor.
Hello.
Yeah, would you please try again?
Okay.
Thank you. It's coming. It shows coming. Something wrong. I don't know why. Yeah, your voice is intermittent and your presentation still not come out yet. And we just tested with another doctor. Her presentation is going well. So I just wondering, is anything in your end? Any traffic? Okay, it's coming. It's coming. Okay, would you please share?
Can I see the slide?
Yeah, I can see the
No.
slide. Please. Yeah, I can see the slide. Please play. Because right now it's in editing mode.
Something wrong?
Your voice is intermittent. You can't wait. I can't see the full screen. I can see your in your editing mode, which is PowerPoint editing mode. Okay, yeah, it's but can you make a full screen?
Morning, Professor Lin.
Hi, glad to see you.
Glad to see you too, Prof.
Dr. Prakoso. Yeah.
Thank you for the invitation for
glad to see you.
Indonesian
Sorry
Heart
about the
Association.
mistake.
Yeah. Thank you.
Yeah. Okay. So you just have the office since December?
Yeah. Yes.
So it must be very busy for the first day.
Yeah. I replaced Dr. Isman.
Oh, okay.
那个怡轩，那个集装，来，我的名要安怎改？我改一个，我改成英文。
你点你自己的名，你在那个与会者 participant，然后你看你 see yourself。
那3点是吧？
有呀，然后你就可以把你的名字
给他3点改名，我看到了，
看到了哈，你可以改哈。Yeah, please send your English name. Thank you.
Okay, Dr. Prakoso, nice to meet you. I'm Dr. Zhuizhen Huang from Taiwan, Taipei.
Nice to meet you,
Co-chair
Prof.
in
Huang.
session. Yeah, okay. Nice to meet you. Nice to meet you. And also thanks Professor Lin's invitation.
Yeah.
And very nice meeting. And so, Dr. Prakoso, you are based in Jakarta or?
Yeah. I'm in Jakarta. I'm from the National Cardiac Center Harapan Kita.
Oh, okay. So Dr. Santoso right now is still active in interventional. Professor Santoso.
Yeah, Professor Santoso is our senior on intervention. He works in Medistra Hospital.
Oh, okay.
Yeah, another hospital.
We know because in the Asian Pacific area, Dr. Santoso is very active and also traveling very frequently before COVID-19. So another hospital, not the same hospital. Okay. Professor Lin, thanks for your invitation. A very nice program.
Okay, I will display the introduction slides for both chairpersons.
I see.
And I will ask Dr. Prakoso to make the opening and also introduce both chairpersons and also read the APHC disclaimer and start the meeting. And two chairpersons, you can share the introduction of the following speakers, and Professor Huang will do the closing remarks at the end.
Okay.
So I introduce the slide, Prof. Lin, yeah.
Yes.
Okay.
You can
Yeah.
say this opening remarks. You can use my annotation as a reference, or you can speak in for for as you like impromptu, no problem.
So, Dr. Prakoso, I think you introduced the first three speakers, and I introduced the last two. Okay.
Okay.
That's, we'll keep online all the time, all the session.
Yeah.
I think.
Here's the introduction for your. I will move for you. I will play back for you. Okay. So you can see all the.
This is this introduction slides for you. Yeah, and
Okay.
all the following speakers and annotation. The part is just the a kind of suggestion reference for you for opening remark, but you can
That's fine, Prof. Lin. I will read your slide. That's fine.
No. You can. I see the intervention and may have different point of view.
Okay,
Today are all speakers. I think they are all interventionists. They should be giving very interesting point of view on this reference. Yeah.
Okay.
We will start on time. And,
4 minutes later we will start. And because I think our doctor from Japan, your presentation. Would you like to try again? We seem to get a very. Any other people? Any other doctor would like to test the slide? Just a few minutes. Yeah, your mute microphone. Your microphone is mute. Yeah, please turn on your microphone.
Can see that.
And I will also turn on the recording.
I'll share the slide.
Okay,
can you see that?
You share the.
Okay.
Yeah, I can see the.
I changed the internet connection.
Okay,
so
and it's better.
I hope
and please
better.
make a play the presentation because right now
that's
we
good.
are in
that's
the.
good.
We see the editing mode. Okay, perfect. It's coming.
Can see the movie?
Yeah,
movies.
very good. Yeah, movie
very
well. Okay, thank you. I think okay. Please stop sharing.
Okay.
And we might.
Thank you very much.
Anyone would like to check your presentation? You may do it now. We have 3 minutes to go. By the way, we already streaming out on YouTube, so you can just if your colleague would like to watch, they can watch. Okay.
Is it streaming to Facebook and YouTube? Okay.
Not good for the Facebook, but I give the link on the Facebook, and the YouTube also have some problem. I will discuss with you later. But anyway, we use another channel. So from Facebook,
so are we using APH crowd?
That's right, APH crowd, correct. Yeah,
okay.
because
so
the one we use
Facebook is still not very good. Yeah.
I try, but seems anyway. I will give you anyway. Okay, see you 2 minutes to go.
We'll switch to APH crowd YouTube.
Already done. And I'm now going to start initiate the recording. So we will put our APH crowd website.
Okay.
And
we'll start on time.
Dr. Hashikata, please
Yes.
turn off your microphone. Turn off your microphone. Okay, got it. Okay, Dr. Prakoso, would you please start the symposium?
Okay. Good afternoon, ladies and gentlemen. Welcome to APSC Cloud Forum of Cardiovascular Disease Series. It's evolving issues in chronic coronary syndrome. So in this meeting, in contrast to acute coronary syndrome, we would like to see about the chronic coronary syndrome, which presents much diverse manifestations, varying from non-vague or typical exertion with chest discomfort. Symptoms scoring, exercise EKG, standard stress imaging includes the radionuclides, computed tomography, CMR, and coronary computerized tomography are sequentially recommend to unveil the risk severity. Optimal medical treatment, or preferably interventional coronary intervention, is recommended for whom with mild, moderate, or high event risk following COURAGE and ischemia trial. In case of significant ischemic territory, the reopening of chronic total occlusion lesions needs strategic evaluation on burden of hibernating myocardium. As the worst scenario, decision-making in chronic coronary syndrome with compromised LV function could be even more difficult, particularly after contradictory message from surgical stage and interventional revived trial. So in this session, me, Raditya Prakoso, as the president of Indonesian Heart Association from National Cardiac Center Harapan Kita, Indonesia, and I'm conjunction with Professor Huang from the Cardiovascular Division, Department of Medicine, National Taiwan University Hospital, Taipei, Taiwan. We'll lead this session for about around 2 hours next. So we will start it. This is the disclaimer that the content of this webinar is copyrighted by APSC and should not be distributed without the prior permission from the APSC. The views and opinions expressed the webinar are those the faculty members and do not necessarily represent those of the APSC. The live streaming content in this webinar will be made available via APSC Cloud, APSC Facebook, and YouTube page. So let's get started. I will introduce the first speaker, Dr. Ellen Sahara from Indonesia, Department of Cardiology and Vascular Medicine, Faculty of Medicine, Universitas Indonesia, National Cardiovascular Center Harapan Kita. She will talk about the CCTA as the priority for diagnosis and risk assessment in symptomatic patients suspected with coronary artery syndrome. Yeah, please, Dr. Ellen, you have 20 minutes. Can you unmute, Dr. Ellen?
Oh, I'm sorry. Okay, sorry. Thank you very much, Dr. Raditya Prakoso, for the introduction. Thank you very much for the invitation, Prof. Jun Lilin, and also Prof. Ju Chen Wang. Today, I would like to bring a topic titled, okay. Yes. Okay. Can you all see my slide? Yeah. So my title today is Coronary CT Angiography as Priority for Diagnosis and Risk Assessment in Symptomatic Patients Suspected with Coronary Artery Disease. As we know that the clinical utility of CCTA across various stages of CAD, from detection of early disease to the assessment of acute chest pain. So it is useful for the risk assessment, disease detection, and guiding therapy. This is the guidelines for chronic coronary syndrome that released in the 2019. As we see here, the coronary CT is the choice of test in the population or patients, symptomatic patient with intermediate to low pretest probability. And also in the chest pain guideline released by SSC AHA in 2021, that the coronary CT angiography is also the choice for imaging diagnostic for the intermediate risk population. And then also in the stable chest pain, for the high risk patient also can have the anatomic testing by CTA. And these are the pretest probability box from AAC in the upper part and also in the lower part from the circulation. As we can see here that most of patients with symptomatic chest pain or dyspnea, they place the intermediate risk probability. So maybe most of them, our outpatient clinic were in the intermediate pretest probability. So that's why the CT angiography had the pivot role for the diagnosis. And also in the chest pain guidelines by AHA, it said that the CCTFF for the patient with intermediate to high pretest probability, especially if the patient is younger or less than 65 of age, or if the suspicion of CAD is less for the obstructive plaque. And why the CCTA is favored? Because its ability to rule out the obstructive CAD and also to detect earlier for the non-obstructive CAD. These two entities is important thing that will guide our management for the therapy or for the prevention. And also the CCTA has high quality image, and the expert usually more widespread or routinely available in many institutions. And also CCTA can evaluate if there is anomaly coronary artery or evaluate the aorta and also the pulmonary arteries. These are the some evidence for the diagnostic accuracy for CCTA that they consistently show the data that CCTA has high sensitivity for detection of more than 50% stenosis or detection of FFR lower than 0.8, while the specificity is not good as the sensitivity itself. From efficiency study that compared the non-invasive imaging and invasive coronary angiography, it showed that CCTA had the highest diagnostic accuracy to detect significant CAD. What is significant CAD? It is the more than 50% of ligament stenosis or more than 70% stenosis in major coronary vessels, or between 30 to 70 stenosis with the FFR lower than 0.8. And also in the Pacific trial that compared non-invasive imaging and invasive angiography, CCTA and PET placed the top score for the highest sensitivity in detecting FFR lower than 0.8. These are the definition of high event risk for several modality testing. For the coronary CTA, we can say that the patient has high event risk if the patient has one of these three vessel disease with proximal stenosis or left main disease or at least proximal anterior descending disease. This is the management algorithm for the stable chest pain. Coronary CTA is preferred for the low clinical likelihood, while the non-invasive or ischemia testing is preferred if the patient has a high clinical likelihood or if the viability assessment is required. And while invasive coronary angiography, we can suggest the patient to have invasive coronary angiography directly if the patient had severe refractory symptoms or a very high clinical likelihood of CID, and also if the LV dysfunction has already happened. From the result of coronary CTA, if the result has high event risk criteria, we can offer the patient to have invasive coronary angiography. But if it's not high event risk criteria, we can treat the patient first with medicamentation. Or if the result is non-conclusive or inconclusive due to due to bad image quality, or if it's not consistent with the symptom or the patient almost asymptomatic, we can refer the patient to have ischemia testing. And these are the evidence for the prognostic implication by doing CCTA in stable chest pain. First, from confirmed study that with the population of more than 20,000 patients, follow up for 2 years, said that the findings of CAD, whether it is non-obstructive or obstructive, it's make the mortality risk is higher. 2.6-fold increase in more than 70% stenosis, and also in the lower 50% stenosis still increase the mortality 1.6-fold. And it is said that the all-cause mortality in the absence of CAD show the low rate of mortality. And second, in the partners registry, that 1,000 patients that underwent CCTA follow-up for more than 3 years, they found that the presence of non-obstructive plaque was associated with higher CV mortality or myocardial infarction. And also in the patient with plaque in more than 4 segments or SI score more than 4 had the same risk on incident of cardiovascular death or MI as the patient with only 1 vessel obstructive CAD. And then the Scott Hart trial that compared the stable chest pain that had standard care only and the patient with standard care plus CCTA. It is said that the addition of CCTA examination resulted in 41 reduction in death or non-fatal myocardial infarction by follow-up for almost 5 years. And thus, in the PROMISE trial that compared the CCTA and the functional ischemia testing in the patient follow-up for the about 2 years, CCTA can has ability to lower the incidence of invasive coronary angiography that's showing non-obstructive CAD, and it's also associated with the higher rate of invasive coronary angiography with revascularization. And also in the diabetic patient that undergoing CCTA, also result in the lower risk of cardiovascular death. These findings is relevant with the greater use of the preventive therapy such as statins and aspirins, as we detect the atherosclerosis much more earlier. So from Scott Hart and PROMISE study, we can learn that the patient knowledge of the presence of plaque make the patient tend to seek the treatment and implement lifestyle changes earlier. So it can prevent or delay the onset of cardiac events. And about coronary CTA angiography use in acute chest pain setting, CCTA can be effective at excluding obstructive CAD in low to intermediate non-STEMI. In verdict trial, CCTA exclude more than 50% stenosis in invasive coronary angiography with sensitivity or negative predictive value of more than 90%, because maybe there are some factors, other factors rather than acute coronary syndrome that can raise the troponin or with the chest pain. And also the CTA resulted in 30% reduction in invasive angiography with a patient with normal or equivalent troponin or ECG. And in 2020, it recommends CCTA as an alternative to invasive angiography to exclude acute coronary syndrome, especially in the patient with low intermediate likelihood of CID or with the equivalent or normal troponin or ECG. As conclusion, CCTA is a recommended initial test for patients with a low to moderate clinical likelihood of CID. The finding of non-obstructive CID lead preventing for further CID progression. And also the CCTA can be useful in low intermediate non-STEMI management. Thank you very much.
Thank you, Dr. Ellen, for the very brief presentation. Yeah, I think it will improve the diagnostic modalities in chronic syndrome. First of all, I would like to ask Dr. Ellen about the low and intermediate risk and coronary syndrome. Do you consider about the risk, the risk of the using of the contrast and also the radiation? What's the issue about that? Thank you.
Okay, thank you very much, Dr. Raditya Prakoso. I think, for the low risk unstable angiophotosis or low risk non-STEMI acute coronary non-STEMI acute coronary syndrome, the issue for using the contrast, I think, is not an issue. If the renal function is in still good numbers. And for the radiation also, I think, it's almost the same with what we use in the invasive angiography.
Okay, Dr. Ellen. Professor Hua?
Yes, Dr. Aiden, thanks for your excellent talk. And because I think the coronary CTA, the cost is different among the Asian Pacific countries. In Taiwan, we are not reimbursed by the health insurance system. So the CTA should be paid by patient himself or the people himself or herself. So I think from this point, what about the situation the CTA used in Indonesia? Is it paid by the health insurance or not?
Okay. Yeah. If the patient from the outpatient clinic, it is paid by the national health insurance. But if it's in the inpatient or from luar, they haven't paid for the coronary CT angiography. We have to propose to the hospital. So due to the based on the hospital hospital judgment to let the patient had coronary CT in the hospitalization or in the ward.
Okay, thank you. Thank you.
Okay.
Okay, since we have another time, any panelists will ask to Dr. Ellen? Okay, if there's no question, I would like to thank Dr. Ellen for a very good presentation. So we move forward to Professor Ratna Mani Gajurel. He's the head of Department of Cardiology, Mamohan Cardiothoracic Vascular and Transplant Center, Maharagung, Kathmandu, Nepal. Please, Dr. Ratna, Prof. Ratna.
Namaste, everybody from Nepal. Just let me share my slide. Is my slide visible to everybody?
Yes, it's clear, Prof.
Okay. First of all, I want to thank APSC for providing this forum of discussion for this chronic coronary syndrome, and I'm very glad to represent my country. The topics assigned for me today is the high-risk event identification in the symptomatic patients with established chronic coronary syndrome, the exercise ECG, stress imaging, or CCTA. I'm not going to go in detail of CCTA because the previous speaker has already been presented very deeply on the CCTA, and there may be some overlap of my slides as the previous speaker. Sorry for that. And I have no conflict of interest in this presentation. I will be focusing on the high event risks of CCS, and I will be discussing on high event risk prediction from different tests in the chronic coronary syndrome. Especially, I will be focusing on the exercise ECG, stress imaging like stress echo, CMR, SPECT, PET perfusion imaging, and briefly on the CCTA. As all we know, initially we used the term stable coronary artery, but since 2019, the stable coronary artery disease has been replaced with the chronic coronary syndrome. And this chronic coronary syndrome is very important. This can go on to develop acute coronary syndrome at any point in the progression of their diseases. The clinical presentation of coronary artery disease can be categorized as either acute coronary or chronic coronary. The chronic coronary is the proper term rather than using the stable coronary. The stable means that people will think otherwise. No, this chronic coronary syndrome is a dynamic process. It has the accumulation of the atherosclerotic plaque and the functional alteration of the coronary circulation after accumulation of the atherosclerotic plaque in the coronary bed. And this can be modified by lifestyle modification, pharmacological therapy, and revascularization. Finally, result in disease stabilization or regression if the patient is getting proper treatment at time. How we approach this chronic coronary syndrome is that there are the different steps. In the first step, we assess the symptom and perform the clinical investigation. In the second step, we do consider the comorbidities and the quality of life. And step 3, there is the resting ECG and some tests we need to run for the patient to diagnose the CCS. And the step 4, we assess the pretest probability and the clinical likelihood of coronary artery disease. And this slide already been presented. And if there is very low pretest probability and no diagnostic testing is recommended, and if there is very high probability of pretest probability, the patient directly sent for the invasive coronary angiography and the needful management. And in between the intermediate to low to intermediate risk group, the patient will send for the coronary CT angiography. And after doing this, in the step 6, we choose the appropriate therapy based on the symptom and the event risks of the particular patient. When we talk about the chronic coronary syndrome, it's already been said that it's the dynamic process, and every patient with the suspected or documented chronic coronary syndrome should undergo an assessment of a future risks of a cardiac event or death. The event risk stratification is recommended based on the clinical assessment and the result of the diagnostic test initially employed for the making the diagnosis of the chronic coronary artery diseases. When we define how much the patient is risk of developing any adverse cardiovascular event, the low risk is defined as a yearly mortality rate of less than 1%, and the high risk is defined as yearly mortality rate of more than 3%. And when we see this table, if the patient is asymptomatic and apparently healthy, we can still screen for the patient. What is the probability of getting high risk or if the patient is low to moderate risk. And if we do the primary screening of this patient, and the patient will have like a healthy sublet, the 10 years risk of cardiovascular mortality will be very low, but still we can get some high risk feature. And if the patient is having symptoms with some features suggestive of chronic coronary syndrome, and if the patient has risks of less than 1%, the patient will have low risk, and if it is 1 to 2.9%, it is moderate risk, and if the patient has the risks of calculated risks of more than 3 and over, the patient will be considered at the high risk, and then this patient will have an annual risk of cardiac mortality. There are different tools for the risk identification of the chronic coronary syndrome, namely the exercise ECG, stress echocardiography, coronary angiography, either CT or invasive functional testing, cardiac MRI, and SPECT or PET perfusion imaging. These are the tools available nowadays in the different centers. And I will be more focusing on the exercise, stress echo, invasive like CMR and SPECT and PET. And when we do this risk identification tool, there are different likelihood of clinical likelihood. The clinical likelihood of cardiac event, if it is less than 15%, this is the showing in the green area, and if we see the red area, the likelihood of range of adverse cardiac event is 85% when we use these tools. How we define the high-risk event by the different tests in chronic coronary syndrome. When we talk about the exercise ECG, if the exercise ECG is TMT is positive, then the cardiovascular mortality is more than 3% per year, according to the Duke-Stromer score. And if we do the stress echocardiography, if the patient has involved more than 3 segments with stress-induced hypokinesia or akinesia, this patient will have adverse prognosis. And when you do coronary CT angiography, if the patient has triple vessel or left main or proximal LAD or the multi-vessel involvement, the patient will have a very guarded prognosis. When you do the invasive functional testing like FFR and IWFR, the patient will have a high risk of cardiovascular event. When we do the cardiac MRI, if it involves the more than 2 segments of 16 segments with stress perfusion defects of more than 3 segments with the dobutamine-induced dysfunctional segment, then this patient will also have a high event risk in the coming years. And if we send for the SPECT or the PET perfusion imaging, the area of ischemia is involved is more than 10% of the left ventricular myocardium. That will also signify the patient is high risk for the cardiovascular in the near future. Coming to the exercise ECG, if it is recommended, exercise ECG is recommended for the risk assessment. It's the class 1 indication. In 2013, it was recommended for diagnosis of the stable CAD. But the recommendation has changed, and the exercise ECG is recommended for the high risk assessment in 2019 guideline by the European Heart Association. How exercise ECG detect ischemia? When we send the patient for exercise ECG indirectly detect myocardial ischemia through exercise-induced ST and T changes. The diagnostic ECG abnormality is the horizontal or downsloping ST segment depression of more than 0.1 millivolt, persisting for more than 0.06 to 0.8 seconds after the J point in 1 or more ECG leads. This is the usual ECG finding when we send the patient of chronic coronary syndrome for the exercise ECG. Exercise ECG is of no value or no diagnostic value in patient with ECG abnormality that prevents interpretation of ST segment, like if the patient has left bundle branch block, if the patient is having pacemaker rhythm, and if the patient is having the Wolff-Parkinson-White syndrome. And if the patient is already having more than 0.1 millivolt ST segment depression in the resting ECG, or who are being treated with digitalis. In these patients, they also have STT changes. So in these cases, the exercise ECG will not give any diagnostic value. When we are calculating the rates of the patients with chronic coronary syndrome by the exercise ECG, treadmill score for the risk stratification. This chart showed the ST segment deviation during the exercise in the left side, and the right side, there is a duration of the exercise. In between, there is ischemic reading line, angina during exercise, and the prognosis. When we calculate the Duke treadmill score, if the patient has ST segment deviation of more than 1 millimeter, and we make a horizontal line towards the ischemic reading, and that will predict the chances of ischemia. And if we the patient has angina during the exercise, and if we draw the line, horizontal line towards the ischemic reading, it will give the chances of myocardial infarction or for adverse cardiovascular in the coming days. And when we go for the duration of the exercise ECG, the more minutes the patient can run despite the symptom, the more patient will get metabolic equivalent. So if we draw a line to the prognostic chart, that will give the average annual mortality from the cardiovascular event. So this is the Duke treadmill score for the risk stratification of coronary artery disease. Actually, what other thing that exercise ECG when we are doing exercise ECG, a fall in blood pressure during exercise is also increased risk for further cardiovascular event. And if there is prolonged ST segment depression of more than 8 minutes into the recovery, that also signifies the high risk patient. And if patient has a slow heart rate recovery after exercise, that also showed the patient has a more cardiovascular event in the coming years. Maximal exercise capacity is one of the most consistent predictor of the outcome that I already told, that regardless of whether the test was terminated because of angina, dyspnea, or the fatigue, if the patient can run more minutes and get more metabolic equivalent, the chances of outcome will be good. And there are the study, and the one study done on the more than 6,000 patients undergoing exercise testing. Each 1 minute increase in exercise capacity was associated with the 12% improvement in the survival. That means when the patient has a more exercise capacity, the possibility of the survival is more. The individual with the chronic coronary syndrome who achieved 5 minutes of activity were at 4-fold higher risk of death than the individual who exercised to 10.7 minutes. That means minutes is very, very important while analyzing the exercise ECG. When we are calculating the Duke treadmill score, there is a formula: exercise duration minus 5 ST deviation minus 4 angina index. The angina index is 2 points for the limiting angina, 1 point for the non-limiting angina during the test. And when we see for the score, if the score is more than 5, that is the low risk group. And if the score is less than -11, the patient is the high risk. And there is chances of more stenosis, and there is chances of more multivessel disease, and 1-year mortality is also high. The 5-year mortality rate with a score of more than 5 is less than 5%, and with a score of less than -10 is 28%. So naturally, if the patient has a Duke treadmill score of minus, is definitely has high chances of coronary artery disease, multivessel disease, and severe stenosis, and high mortality in 1 year. Another test, non-invasive test for stratifying the risk for the chronic coronary syndrome, is the stress echocardiography. This stress echocardiography yields prognostic information for risk stratification of the patient with known or suspected coronary artery disease. Our normal study is the good prognosis, and that signifies the patient is in the very low risk group. And the abnormal study showed the patient is in the increased risk of cardiac event, and they are labeled as the high risk patient. What are the risk stratification by the stress echocardiography? If the patient has patient will be labeled if the patient has a high risk group of more than 5% cardiac event, and the low risk less than 1% for the cardiac event, and the intermediate is between 1 to 5% of the cardiac event. And a patient with only apical ischemia, like let's say single vessel disease, is at substantially lower or intermediate risk than a patient with both anterior and inferior ischemia and the cavity dilatation after stress, multi-vessel CAG. This will show the patient will have a single vessel disease involvement. There will be less chances of risk, and the multi-vessel involvement and the dilatation of the chamber in the echocardiography will show multi-vessel involvement and the severe coronary artery disease, and this patient will be considered that he has a high risk for the cardiac event. And the another is the peak wall motion score index. Following stress was derived from the cumulative sum score of the 16 left ventricular wall segment divided by the number of visualized segment. Peak wall motion score index was able to effectively risk stratify the patient with the 3 groups for the cardiac event that I already told. Low risk is less than 1% per year, intermediate is the 3.1% per year, and if the patient has this score of more than 5.2 per year, will be labeled as the high risk group. A normal stress echocardiography equivalent like WMSI score of 1 confer a benign prognosis, and if the peak WMSI is more than 1.7 and the cavity dilatation with the left ventricular ejection fraction is less than 45% are independent marker of the patient at a high risk and adverse clinical outcome in the coming years. And these graph also shows the same. Another test we can do is the stress cardiovascular magnetic resonance imaging for the chronic coronary syndrome. Actually, this is the cost-effective method, and this is the non-invasive test. This is accurately assists the myocardial ischemia, and this accurately assists the myocardial viability and accurately assists the cardiac function. And this is also without the need for ionizing radiation. So this MRI, CMR is getting more popular nowadays. And this will give the comprehensive assessment to the diagnostic and the prognostic relevance that I already told. The myocardial perfusion imaging we can do, and the late gadolinium enhancement we can do, and myocardial T1 mapping technique also we can do. And this is directly related to the number of subsequent CAD events in the coming years. This will define the extent of the ischemia, the presence of post-infarction scar, and native T1 of non-infarcted myocardium. We can also make the cine cardiac imaging, and this will give the useful assessment of global and the regional ventricular function for both the left ventricle and the right ventricle. This LGE identify the myocardial scar, estimation of the myocardial infarction size, assessment of the myocardial viability, and detection of the perfusion indicating myocardial ischemia. So CMR was associated with the lower incidence of the coronary revascularization than FFR. If we do FFR, the chances of revascularization, the result, when we compare 36 versus the 44%, the p-value is significant, which led to a considerable reduction in the unnecessary invasive angiography to 51% of the patient going to have a negative CMR test. So sometimes this CMR will avoid the unnecessary invasive test and the invasive pressure monitoring. There are mode of therapy. When the patient will send for the invasive therapy, there will be a threshold of more than 10% ischemic myocardium as a benchmark for the mode of therapy when we send the patient for invasive. If the patient has less than 10% ischemic myocardium, medical therapy will suffice, and they are in the reduced risk of death compared to the revascularization. Patient with more than 10% of ischemic myocardium, coronary revascularization compared to the medical therapy demonstrate the reduced risk of COD and the all-cause death. How we predict the risks and the prognosis by the CMR. It's a moderate to severe perfusion defect in the stress. CMR has been found to predict the cardiovascular event, And more specifically, the patient with more than 2 of 16 segment with stress perfusion defect or more than 3 segment dobutamine-induced dysfunction are classified as having high event risks. And the CMR-derived coronary flow reserve is another independent predictor of the major adverse cardiovascular event. Adenosine or regadenoson stress CMR we can do. The normal perfusion, low risk for coronary revascularization, non-fatal myocardial infarction, and the cardiovascular death. Dobutamine CMR nowadays used predominantly in our part of the world, important role in predicting cardiac death and the non-fatal myocardial infarction during the long-term follow-up. One of the South Asian studies showed that the implementation of the CMR-derived factors such as infarct size and the wall motion score index with left ventricular ejection fraction can improve the risk stratification of the patient with coronary artery disease and can lead to cost-effective therapeutic strategy. LG can predict the size of the ischemia and the presence of dysfunctional viable myocardium, and independent predictor of the mortality in patient with the ischemic LV function. And this, that LG also can explain the scar extent, and this is significantly associated with the appropriate ICD therapy. So CMR can be useful for identifying patient in the high risk of future lethal myocardial event and the arrhythmic event. Coming to the nuclear imaging, the stress spec or PET myocardial perfusion imaging is nowadays available in the most of the center in the developed countries, and some of the center like in our country this is not available, but still we can get many information from this spec of the PET. Major clinical indication for detection of the coronary artery disease. I can rule out the cause of chest pain, risk stratification for the prognostication of the coronary artery disease. And the normal stress myocardial perfusion scan is the excellent prognosis with less than 1% annual rate future annual death or the non-fatal myocardial infarction. And greater the extent and the severity of ischemic perfusion defects seen on the stress imaging, but improve on resting images. And the greater the subsequent death or infarction rate during follow-up. This produces an image of regional myocardial tracer uptake and reflect the relatively myocardial blood flow at rest during exercise, dynamic exercise, and the pharmacological state. Increase uptake of the perfusion agent in the lung. That means it identifies the stress-induced ventricular dysfunction. When there is ventricular dysfunction, there will be increased uptake of the perfusion agent in the lung. This means the patient will have a severe or extensive coronary artery diseases. There is transient ischemic dilatation and reduced post-stress ejection fraction. This also showed the patient has possibility of coronary artery diseases, severe coronary artery disease. How this spec will stratify the risks. Normal PET scan, that means it's a pool analysis of the many studies showed there is the event rate of 0.6% per year for a patient with a normal scan. Moderate or severely abnormal scan, high risk of cardiac death or non-fatal myocardial infarction during follow-up. In a pool data from the different studies showed that with the abnormal scans had an annual cardiac death or infarction rate of around 6% per year. So this spec will predict the risks of future myocardial event if the event rate of more than 6%. When the patient is diabetic and chronic kidney disease, the chances of event is very high in this patient with a normal or abnormal scan. Whether this patient will have an abnormal or normal scan, and this patient is compared to the patient with a normal renal function, this patient will definitely has the highest cardiovascular event. 10% is the landmark. If it is less than 10% ischemia, the problem will not be that much. If it is the ischemia is more than 10% in the myocardial perfusion imaging, the cutoff where outcome are better with revascularization. Greater the ischemic burden and the ischemic images, higher the cardiovascular. That means more than 10% of the myocardium involvement means this patient needs some intervention. exercise or pharmacological aspect for risk assessment can be useful for the patient who have high coronary calcium score on CT scanning, particularly if they are diabetic. Some patients with intermittent stenosis, like 50 to 70% on CT angiography, may benefit from stress perfusion imaging to determine the physiological significance of non-critical stenosis. The prognostic value of the stress aspect is enhanced by the assessing the functional variable on gated images. Imaging of myocardial viability can be undertaken with either resting and the delayed. In 3 hours, T1 201 imaging or rest image with the either technetium 99M systemite B or TC 99M tetrosophosphine. Abnormally contracting segment with more than 50% tracer uptake have good viability, and substantial number of them will improve function after revascularization. And coming to the PET, scanning PET, myocardial perfusing image is in a single study session we can do. It's accurate measurement of the myocardial perfusion. They will give the absolute myocardial blood flow and the function at the stress and the rest. This is the dynamic myocardial blood flow analysis, and the additional prognostic value beyond the relative perfusion imaging can be given by this PET scanning. Compared with the SPECT MPI, PET MPI provides the higher diagnostic accuracy using the low radiation dosage during a certain time period for the detection of the coronary artery diseases, whether the patient has acute or chronic coronary syndrome. PET imaging uses 82 RB, 13N ammonia or 150 water as a radioactive material perfusion tracer to evaluate the myocardial perfusion and function at rest and during the pharmacological stress. This will provide the information on the presence or absence of the myocardial ischemia, location and the extent of ischemia, myocardial infarction, residual viability, and the ventricular function. The PET scan can also quantify the myocardial blood flow per ml per minute in the per gram tissue of the myocardium, which allows the detection of the microvascular diseases and improve the evaluation of the ischemic burden in the multivessel coronary artery disease. This means those patients who has no epicardial diseases, if we send this patient for the PET scanning, microvascular angina patient will also be revealed by doing the PET scanning according to the this quantity of myocardial blood flow per ml per minute per gram. Let's say this is the example of 46 years male, typical history of.
Right now, your time is only 2 minutes more.
Okay, I'm nearing to my finishing my presentation, and the PET showed an inferolateral defect, and the blood flow is also, and CT showed there is lesion, and if we say an angiography, there is a significant lesion, and FR was very significant. So the PET is very important. And how we do the risks. Normally MPIs can provide low risks, and abnormal test will give showed the high cardiovascular in the near future. And I'm not going to go in detail of this computer, this CT coronary angiography, as the previous speaker has already been presented in detail about this. And you can see the different type of sign. This is napkin sign, and low attenuation plaque identify the CCTA is more frequently related to the presence of ischemia. Spotty calcification, positive remodeling, and the low attenuation causing present more acute than the stable coronary artery disease. And the Scott Hart study and this PROMISE trial also says accurately says the CCTA will predict the future cardiovascular. Coming to my summary part, the high event risk identification in the symptomatic patient with established chronic coronary syndrome can be done by any of the tests, provided they should be selected logically in the particular patient, and it depends on the availability of the test. And we can send for the patient exercise ECG, stress imaging, stress echocardiography, cardiac MRI, SPECT, PET, or finally this coronary CT angiography. It depends upon the patient's profile and the availability of the test. Thank you.
Thank you for Prof. Ratna for a very brief presentation. So I would like to ask you about how is the situation in Nepal, like in Indonesia. So it's very huge countries with the not the good distribution of the facilities. And what are you recommending regarding, for example, in Nepal and your country, what's the best modalities that's available to in those this hospital in Nepal?
This is a very relevant question. Actually, Nepal is one of the developing countries, and there are very limited resources, including the resources regarding the manpower, the availability of the services. No, and we don't have a very great health insurance system, because the patient need to pay from their pocket. So we should be very selective for sending the test for the patient. So when the patient come to the clinician or the cardiologist, first always we need to ask what is the probability of getting the coronary artery disease, and accordingly what we are doing here is first low to intermediate probability we are sending for the exercise ECG, and now CT coronary angiograph is available in the different part. So we can send the CT coronary angiography for those who are really paying and needed patient, and many patients who are taking like if they have risk factors, diabetes, hypertension, angina type of patient, and there is a high probability of getting coronary disease, then we send the patient for the coronary angiography directly. We just don't want to spend the money on the other tests. This is the scenario in Nepal.
Thank you. Professor Wang, one short comment?
I think one brief comment. Do you use the pharmacological stress echocardiography or the bicycling ergometer stress echo in Nepal?
Yeah, in Nepal, we are doing pharmacological stress echo, like we do the dobutamine stress echo. Yes, we are doing.
Okay, thank you, Prof. Ratna, for a nice presentation. Then we shall move to the next speaker, Dr. Panipa Swanasom from Thailand. She is the director of the Cardiac Catheterization Laboratories, Division of Cardiology, Department of Internal Medicine, Faculty of Medicine, Chiang Mai University, Maharat Nangkorn, Chiang Mai Hospital, Chiang Mai, Thailand. She will talk about the PCI additional to our optimal medical treatment alone for chronic coronary syndrome with a high event risk insight from ischemia trial. Please, Dr. Panipa.
Yeah, so thank you for your kind introduction. So I cannot share my screen because someone has already still sharing their screen. So if the admin can make me share my screen, that would be great.
You may share now.
Okay, thank you. Let me see. Okay, I think everyone see my slide now. Okay, thank you
clear.
very much for having me. So my topic as seen from this slide. So because the topic is about insight from the ischemia trial, so let me do some brief introduction for the ischemia trial. So this is a study that study in the stable patient with a moderate or severe ischemia. So as you can see, the criteria of the ischemia is on the right-hand side with a nuclear, echo, CMR, or exercise stress test. And moreover, they also send a patient for the coronary CT, but some would not require because of their kidney function or because of coronary anatomy previously defined. And as you can see, they run down the patient for the invasive strategy plus OMT plus CAT, or in another arm is conservative with the OMT alone and CAT reserved for the OMT failure. So it's been that it's not compare between CAT with the revascularization or medical treatment. It's just only the randomization to see what is the best initial strategy. So, but the thing that is really important for us is to know about the major exclusion criteria, because if we have our coronary syndrome with this exclusion criteria, we cannot apply the result of the ischemia in such patient. So the exclusion criteria are the patient with heart failure, unacceptable angina despite medical therapy, patient with EF less than 35% ACS within 2 months, PCR CABG within 1 year, and the patient with the eGFR less than 30 milliliter or on dialysis. So the interesting about the CCTA is that they got the patient to study for 73%, and the criteria of the CCTA with the functional test is more than 50% stenosis. With the exercise stress test, that should be 70% of the proximal or mid vessel. And the patient who would have a skin failure is the patient with the left main, non-obstructive coronary, or the car lab have already screened for the ischemia trial and find that there's no insufficiency of ischemia. And the primary endpoint is a time to CV death, MI, hospitalization for unstable angina, heart failure, or resuscitation from cardiac arrest. And this is a primary outcome of the study. So as you can see, there was no any difference of the primary outcome between the patient who has initial of the invasive or have initial of conservative. But interesting that we can find is that even for the MI, which is actually the main outcome is not different, but the invasive would have a higher rate of posterior MI, which is actually, I think it makes sense because it's posterior MI documented by the type 4A of type 5 MI, according to the universal definition. For the conservative, the high rate of spontaneous MI was found, and is a MI type 1, type 2, 4B, 4C MI. So the conclusion of study is that they cannot find evidence that the initial invasive strategy can reduce the risk of the ischemic cardiovascular event or death from any cause at the median follow-up of 3.2 years. And later, they just published the ischemia extend. They extend the follow-up to the 5.7 years. And as you can see, the all causes is similar between the conservative and invasive. However, when we saw this, the result of the ischemia, we think that, okay, mostly we can initiate with the conservative first, but we also should not leave the patient who could gain the benefit from the initial invasive strategy behind. So what kind of such patients? So let me show you the patient who would have benefit from the initial invasive is the patient who has symptoms. So if you can see from this graph, which is a SAQ summary score, the patient who has received invasive would have a durable improvement of angina control and quality of life, but with the condition that they must have angina. Either they would have daily, weekly, or monthly, but the probability that they will have durable improvement will be fine in the patient who received invasive, and with the basis that the patient got optimal medical therapy, but still have symptoms. So as you can see, the patient with the baseline with the angina would have much benefit with the invasive. For the patient who do not have angina, there's no benefit of the invasives. And the next one is who would have the benefit from invasive is the patient. So this is the data from the European country. They have about 30,000 of patients with a 5-year follow-up. So as you can see, the patient with both angina and prior MI, if they have such kind of problem, that would have, I think, they would have deserved for the intensive treatment, and sometimes they may have improved with the invasive strategy. So, however, as mentioned here, if we have one patient who come with a coronary syndrome, and we ask the patient to go for the medication, so we think that actually the patient who non-adherence to the conservative may get worse event. But if you can see from this summarize of the graphic abstract, it's a similar detrimental effect of the medication non-adherence. So if the patient is non-adherence, even we do the invasive or we do conservative, the patient would not getting better. So it's really important to pursue all the patient to go for the medical adherence. And the next one about the ischemia trial, the thing that is really interesting is the rate of hospitalization for heart failure. So as you can see in the patient with the invasive strategy, the patient with the invasive strategy would have higher hospitalization from heart failure. However, they have the study, they want to see that who would have benefit from the revascularization. So they found that the patient with the myocardial ischemia, with the heart failure, with a left ventricular ejection fraction between the 35 to 45%. The early invasive strategy might improve the event-free survival. So as you can see with the dash in the black is conservative with the history of heart failure or LV 35 to 45. So they got primary endpoint about 29.3%, whereas if the patient got revascularization, the event will be reduced about 12.1%. So this is just only the hypothesis generating, but I think this is also the thing that we have to discuss with the patient if they have profile like this. And this is a predict probability of the primary outcome, the all-cause mortality and severe mortality according to the baseline LVEF. If the patient has a baseline LVEF less than 45, the patient may have a benefit from the invasive treatment. Okay, so the next, some would say that, and how about the completeness of revascularization in the patient with the chronic coronary syndrome? Because for us, like interventional cardiologists, if we are going to do the revascularization, we also try to do the complete revas. But as you can see in the ischemia trial with the anatomic complete revascularization, they achieved that about 43.6%. For the functional complete revascularization, they achieve about 58.5%. And as you can see, if it doesn't matter whether the patient achieved the anatomical complete revascularization or functional complete revascularization, it's similar. So we can just only consider for the anatomic complete revascularization and it would be fine. And this is the table to show you that for the primary endpoint, just only we think about the invasive and conservative. The primary endpoint is about 2.5, but if in the patient who were in the invasive and achieve anatomical complete revascularization, we can push the patient a little bit and the event will be reduced another 1% to 3.5. So what does it mean for this one? It means that if we have to do the invasive for the patient, we should try our best to complete revascularization if it's only focal, single, or two lesion. And but if we see that from anatomy is diffuse lesion, so PCI may not be the good thing for the patient. Maybe we have to think about other things like CABG or to make an optimization of the medication. So this is just only the message to say that if we're going to do the revascularization for the patient, aim for the complete revascularization. The next one is, and because the topic is that PCI additional on the medical therapy in the CCS patient with high event risk, but who have the high event risk. So we have to do like to define the definition. So as you can see, this is the definition of all the non-invasive tests. This is in the chronic coronary syndrome 2019 guideline. So in the guideline of revascularization, everyone see that this is before we have the ischemia trial. But if you can see, this is left mid is exclusion, EF less than 35 is exclusion, single remaining is not exclusion in the trial, but we know that it should be the exclusion because it's just only single remaining of the coronary. And symptoms also exclusion, because if the patient still got symptoms even with the medical therapy, is also the exclusion. But for the proximal LAD, more than 50%, multivessel disease, or large area of ischemia, more than 10%, that's still the high even risk for the patient or not. Also, this is so from Europe we go to the US guideline. This is the guideline for the patient with chest pain, with stable chest pain and non-CAD. And as you can see, the definition of the high-risk CAD in this study is the patient with the left main more than 50% and anatomical significant triple vessel disease more than 70% stenosis. So let's see that how we use the ischemia to apply with this patient with the definition of high even risk, which is different. Okay, so everyone know that 10% of ischemia is derived from this study since 2003, because if you can see the graph that across at 10% with the revascularization may have the benefit more than a medical therapy, but at that time, is 2003 without good DAPT, good statin, no PCSK9, SCI, it's just like start to use. And if you can see, this is the definition of the ischemia in the ischemia trial. And this is all the definition they use in the trial. And the patient in the trial is about 50% with the severe and the moderate about 30%. So it is really interesting to see that 20% of the patient do not receive revascularization, and because of non-obstructive or so that should be like INOCA, 60% receive coronary angiogram and see that is significant lesion, and 1/3 unsuitable for any mode of revascularization. So the thing is that they include moderate to severe, but 20% no revascularization because of non-obstructive. So this is really interesting because they want to know whether the ischemia severity is associated with the obstructive or non-obstructive coronary or not. And this is really, for me, is interesting because the patient with INOCA, we also can find that they have a severe ischemia, even they do not have obstruction. So it's really makes sense that why we have to like rest the choricity to use. And when you do the relationship between the severity of the ischemia and the test, there's no any association. So it means that now we have to think about to send the patient for the coronary CT more and more. And in ischemia, about 75% of the patient got multivessel disease and 87% got LAD. And so they want to know that, okay, so if the functional ischemia doesn't have any association with the outcome of the patient, so how about the anatomical? So they have a Duke prognostic score with a definition like this. They do the analysis, and this is the ischemic severity, like severe, moderate, and mild from the functional test. And as you can see, there was no any association. But if we go for the Duke score, like triple vessel disease or double vessel disease, more than 70% with proximal LAD, this show that it associated with the higher risk of the CV death, the primary endpoint. So this is showing that it's really important to know the anatomical, and then you figure out later what you want to do with the patient. So this study in the JACC imaging say that the severity of ischemia was not associated with the severity of the non-obstructive atherosclerosis. So I think, and they also do the analysis about anatomical severity of the CAD by using Duke score. And as you can see, the all-cause mortality no different. But what makes different is if the patient with a Duke score 6, which is the triple vessel disease more than 70%, double vessel disease with diameter stenosis more than 70%, with proximal LAD, the patient who got invasive therapy would have a less MI. So if we take a look at the sub-analysis in the ischemia extent, and we see the same observation, even the interaction is not significant, but patient who got multivessel disease more than 70% would have more benefits, tend to have more benefit to reduce the CV death. And some would say, okay, yeah, but you know, it has to be like trade-off with the procedural MI with the invasive. But I would like to point out that this is analysis with the procedural MI for the all-cause death or CV death. There's no any effect of the procedural MI with the all-cause death and CV death. But what affect the death of the patient and CV death of the patient is type 1 MI. So this is just only to make a point that actually, if the patient needs to receive the invasive strategy, it's fine, because at least you can reduce the type 1 MI for the patient. Okay, so I have last 2 minutes that I would like to summarize in about 5 slides here. So this is the data, which is the meta-analysis from the study that study elective coronary revascularization plus medical therapy versus the medical therapy alone. So as you can see, they have the 25 randomized trial with the number of patients about 19,000. With the cardiac death, revascularization and medical therapy can reduce cardiac death and also the spontaneous MI. Either the patient with the ACS or without, as even they do like to cut ACS out, to cut CTO out, to cut CABT out, the patient would have benefit from the revascularization. And the longer the follow-up, the duration, the greater the reduction we'll find. As you can see, this is like reduction about 21% of the cardiac death.
Excuse me, Dr. Panipa, your time is 2 more minutes.
Oh, so yeah, but I think I would have like the last 2 slides almost done. So this slide, I just want to say that if you read the journal and they say that, yeah, but you know, the ischemia is just only 4% to be eligible in the real world practice. But if you take a look at what makes the patient not eligible, is because there's no document of the myocardial ischemia. So this is a thing that I think that we can improve in our practice to send the patient more for the like myocardial ischemia, or we send the patient more for the CT to think about what we should do for the patient. And actually, this is the same, the similar observation in the US. Only 13.5% of patients undergoing PCI met the criteria. So the take-home message for this topic is that ischemia cannot be applied in the patient with exclusion criteria like left main or EF, ACS less than 2 months, severe symptoms, and severe ischemic is no longer indicated for revascularization. So as you can see, there's no any association with the outcome of the patient. And maybe CCDA would be a more efficient to use to for the risk stratification for the patient. Of course, initial invasive strategy and initial conservative strategy provide a similar primary outcome. But if the patient with angina, invasive provide a more durable improvement of the angina and quality of life. And if we have to do the revascularization, try to do complete revascularization because it can reduce the primary outcome and also major secondary outcome, which is a CV death or MI. Thank you very much.
Thank you, Dr. Panipa, for the very clear presentations. It's very nice to see how you talk about the application of the ischemia trial. Since I think in Thailand, also in our Asia Pacific countries, is the ability of cath lab is not distributed well. I think in the most countries, also in our country. So what is the recommendations? Since maybe if in some districts there's no availability of the cath lab or just optimal medical treatment for high risk patient. What's your opinion, Dr. Panipa?
Yeah, I think actually it's just only to like make us feel like relief to say to the patient that okay, so within these 3.2 years or like 5.7 years, you have like moderate to severe ischemia, but you do not have angina. So this is what I'm going to say to the patient. If you do not have angina, just stay with the medication. But if they have angina, we can also go for the invasive strategy. But I would say that if I'm not the interventional cardiologist, I would say just find a center that they can fix your coronary without the procedural MI. I mean, that should have a good record. Or actually, if for the interventional cardiologist, they also have to take a look at the coronary angiogram of the patient and see whether this lesion, what the modality we can offer. Like if it's easily to fix, it's fine. We can like make sure for the patient that, okay, if we can do the complete revascularization, that can make you have a better outcome more than conservative. Yes, but if not, we have to like think about CABG, or if it's really unsuitable with the medication, it's also fine, because as we see from the result, 3.2 years with all-cause mortality equal, 5.7 year all-cause mortality equal. But yes, they may have MI in the future, but that's a price to trade. Yeah.
Thank you, Dr. Panipa. Professor Huang, please.
No
Any question? Okay, so thank you, Dr. Panipa, for the presentations. And then we move forward to the next session. Professor Huang, please introduce the next speaker.
Okay, I'm Dr. Zhuizhen Huang from National Taiwan University Hospital, is the past president of Taiwan Society of Cardiology. Next speaker will be the Dr. Jerry Kwa from Singapore. Dr. Kwa currently is cardiology consultant at Ng Tin Fong General Hospital and also director of cardiovascular catheterization laboratory, visiting consultant at the National University Hospital Singapore. And Dr. Kwa's topic is the role of CTO intervention in symptomatic patients with chronic coronary syndrome, decision-making key points. Dr. Kwa, please.
Hi, very good afternoon to everyone. So thanks to APSC for the kind invitation. I'll just share my slides. Okay, then, yeah. So the topic of my talk today is the role of CTO intervention in symptomatic patients with chronic coronary syndrome, decision-making key points. So this will be the objectives that I'll be going through today. So I'll be talk about the definition of CTO, adverse outcomes associated with CTO, challenges with CTO PCI, studies. I think someone's mic is.
What is word bias? What your total word?
Timothy, could you help to turn off the other person's microphone?
Yeah, I already done. Okay. Please go ahead.
Right, thank you.
Dr. Huang, please.
Challenges with CTO PCI, and then I'll talk about some studies to support CTO revascularization, and then I'll also go through some guideline recommendations. So I'll just start off with a clinical vignette first. I'll talk about two of my patients. So patient A is a 55-year-old gentleman with a smoking history of hypertension. He's angina, currently just on one anti-anginal agent. His angiogram was done, which showed a mid-LED 100% occlusion with a mid-RCA 80% stenosis, normal LV function on echo, and he declined CABG. So this is his angiogram. So you can see here that he had a proximal LED 100% occlusion. Collaterals are actually filling in from the RCA. And then I'll go on to talk about patient B, who's a 57-year-old man with a history of hypertension and hyperlipidemia. He had angina on two agents, bisoprolol as well as isosobite mononitrates. Also had a normal LV function on echocardiogram, and his angiogram showed a proximal LED 90% stenosis with RCA CTO, similarly declined CABG. And this was his RCA CTO lesion. So you can see here proximal to mid CTO with some bridging collaterals that were filling the PDA and RPL. So what is the definition of a CTO lesion? So CTO lesions are completely occluded arteries with hemi-zero flow. And they, by definition, they've been there for an estimated duration of at least 3 months. They're actually present in about a third to a quarter of the diagnostic angiograms that we do. And the RCA is more frequently involved than as compared to the LAD and circumflex artery. So what are some of the adverse outcomes that are associated with CTO lesions? So we know that CTO lesions are almost always likely to be ischemic. So in this study where they looked at 50 patients with CTO with 50 control non-CTO lesions, what they did was quite interesting. They actually crossed the CTO lesion and then did a little ballooning with a 1.5 balloon. But even with the most well-developed collaterals, they found that almost all CTO lesions had an ischemic FFR. There's less than 0.80. We also know that CTO lesions are associated with ventricular arrhythmias. So in this study, the Vector study, they looked at patients with an ICD implanted with coronary artery disease. And they found that in the presence of a CTO, patients were more likely to experience ventricular arrhythmias. And in these two prospective studies, basically what they found was that in patients with CTO lesions, these are actually associated with increased mortality. So what are some of the challenges that we face with CTO PCI? So in this descriptive study of a US registry that looked at year 2009 to 2013, what you can see here is that CTO lesions have actually much lower procedural success. So 59% procedural success with CTO PCI as compared to non-CTO PCI with a success rate of 96%. You'll also find that CTO PCI is associated with a 2 times higher event rate. And also, very obviously, we use much higher contrast volumes, almost 250 mils in CTO PCI, and a much longer fluoroscopy time as well as compared to non-CTO PCI. And this study was quite interesting. They looked at success rate with your CTO volume. So you know that in interventionists who do less than 5 CTO PCIs a year, your success rate is just about 50%, so it's 1 in 2. But if you were to increase your CTO PCI volume to more than 10 a year, then your success rate actually goes up much higher to 75%. So in this study where they looked at setting up a CTO program in this single center study, they found that actually having 2 operators per case actually increases your success rate and makes your CTO program a much more successful one. So not all CTOs are built the same way. So in this very widely used JCTO score, where they look at these 5 lesion characteristics: blunt entry stump, calcification, bend more than 45 degrees, if the CTO length is more than 20 mm, and if there was a previous failed attempt, then every successive point actually increases the difficulty of your CTO intervention. So this actually helps to predict wire crossing within 30 minutes. And the success rate will actually range from 88 to just 10% with your increased JCTO score. So why then do we want to do or attempt PCI for CTO? So in this multi-center prospective study, what they did was they looked at the CPET done pre and post CTO PCI, and they found that at 7 months follow-up, there was an improvement in your VO2 max. And in this registry study, what they looked at was they found that with successful CTO revascularization, there was an improvement in your Seattle and angina questionnaire quality of life score. In this meta-analysis involving 2,000 over patients, for a mean follow-up of 9 months, they also found that with a successful CTO PCI, this was associated with an improvement in your LV ejection fraction. And in these three studies, this Italian registry data, UK registry data, and this meta-analysis, they also found that CTO PCI improves survival. However, we all know that all these observational studies are prone to compounder and selection bias. And in patients with failed CTO cases, these were the patients who are more likely to have complex coronary artery disease. They're also more likely to be patients with complex or a lot more comorbidities. Also, if you have a failed CTO cases, that itself is also more likely to be associated with procedural complications. So therefore, your successful CTO PCI cases will actually skew your data. So we actually need more randomized clinical data to assess the true benefits of CTO PCI. So there has just been a few RCTs that were done for CTO PCI. So I'll be going through a few of them. So the first one is the REVAS study. This was done with 200 patients who were randomized to CTO PCI versus medical therapy. And it was a disappointing result in that they found that at 6 months follow-up, there was actually no change in your segmental wall thickening between the two groups. The next RCT, this is the EXPLORE trial. Basically, this was 300 patients who came in with a STEMI and also had a concurrent CTO. So in these patients, they were then randomized to CTO PCI versus medical therapy. And in this study, there was a 77% success rate in CTO revascularization. But again, the result was a disappointing one. At 4 months, the mean LVEF actually did not differ between the two groups. However, they did do a subgroup analysis and they found that if you do PCI of a LED CTO, then that is significantly associated with a higher LV ejection fraction. So this is one of the landmark trials, the Euro CTO trial. So this was multi-center, 396 patients. What they were trying to assess was angina, which was assessed by your Seattle angina questionnaire. This was an intention to treat analysis. So there was actually 13.4 failed procedures, or rather 86 to 87% successful PCI. And in the medical therapy group, there was actually a 7.3% crossover. So in this, this was actually a positive trial in that they found that in the PCI group, there was actually a greater improvement in angina frequency. And this was another landmark trial, the Decision CTO trial. This was done or published more recently in 2019. So this very big study, 834 patients randomized to PCI of your non-CTO and your CTO lesions versus just PCI of the non-CTO plus medical therapy for the CTO lesion. So in this study, there was a 91% success rate in CTO revascularization. But again, this was a disappointing conclusion. There was no difference in major adverse cardiac events between the two arms. Some criticisms of the study included that firstly, the enrollment actually occurred before the PCI of the non-CTO lesions. Hence, the CTO lesions itself actually may not even causing any symptoms to the patient. Secondly, the study was underpowered. And lastly, there was actually quite a high crossover. 1 in 5 actually crossover from the medical arm to the PCI arm. So what do the major guidelines then tell us? So in the 2018 revascularization guidelines, they gave a 2A indication for PCI or CTO lesions, and they said that this should be considered in patients with refractory angina or with in patients with CTO that's actually supplying a large area of myocardium. The ACC/AHA 2021 guidelines was not so kind, so they actually gave it just a 2B indication, and they said that the benefit of PCI CTO to improve symptoms is uncertain. Of course, this recommendation may be due to the fact that of the results from the decision CTO, which came out after the ESC guidelines. So what are my 2 cents worth? So I think, firstly, we have some RCT data to support CTO PCI for symptom relief. We also know that we have some observational data and RCT subgroup data to support CTO PCI to improve LV function. We also know that not all CTOs are the same. Some are more difficult than others, or more technically challenging than others. And we also know that not all interventionists are the same. There are certain interventionists with a particular interest in CTO PCI, and therefore more have the more necessary skill set to do CTO PCI. So with that, I have this is my own flowchart or algorithm when I have a patient with a CTO. So my first dichotomy would be to decide if a patient has lifestyle limiting angina despite fixing his non-CTO lesions. So if the answer is yes, then I will look at the lesion itself to see how difficult this CTO lesion is. Of course, I will also take into account patient factors. So for example, if you're an elderly patient or in patient with significant renal dysfunction or other comorbids, like for example, he's bedbound or he has cancer, then certainly those are reasons for me to not touch the CTO. But if the CTO lesion is an easy one, then yes, I will offer revascularization to this patient. If the CTO lesion is not going to be an easy one, i.e. with a high J CTO score, then I will discuss the complex procedure with the patient, telling him about lower success rate with higher expected complication rate, and then I will refer him to an experienced CTO operator, and in my case will be either Prof. Tan or Professor Adrian Low in NUH. So if the patient doesn't have angina, then my next dichotomy will be whether this CTO lesion is supplying a large amount of myocardium. And if the answer is no, then of course I will just leave the patient on medical therapy. But if yes, the CTO is going to be an important one, then I would go back to think about how difficult the lesion is. And if it's simple, offer revascularization. If it's complex, I would again discuss with the patient and then refer him to an experienced CTO operator. So going back to my 2 patients. So patient A, you can, if you recall, he's the patient with angina, just on one anti-anginal agent. However, his CTO is the LAD CTO that subtends a large amount of myocardium. And I felt that the lesion was a simple one. There was a blunt stump, but otherwise a very short segment. So I went on to perform this at my center with antiquate wiring, and the procedure was actually quite quickly completed within 1.5 hours. And in patient B, this was the patient with angina on 2 anti-anginal agents. He had a nuclear test done, which actually showed that this area of ischemia was quite large, and you can tell that the lesion length is extremely long, and this was going to be a complex CTO procedure. So I referred him to a tertiary center to be done with a CTO operator. And you can see that we managed to cross the lesion and stent the lesion, but unfortunately there was very poor distal flow in this patient, likely due to microvascular obstruction. And in the end of the procedure, we had a TIMI2 flow. This is despite giving him hyperemic agents. But and the procedure was actually quite long. It took 3.5 hours. We used antiquate wiring, parallel wire technique. But fortunately for the patient, he had a repeat nuclear scan done with 1 month later, actually showing complete improvement in his nuclear scan, and there was no more ischemia on his stress test. So with that, come to my last slide. So in summary, I think the most important indication for revascularization of CTO symptoms. Important considerations in decision-making are technical difficulties of the CTO lesion and of course the expertise of the operator. And I think we definitely need more RCTs to further support our decision in CTO revascularization. Thank you.
And thank you for Dr. Kwa's talk and mention the very important issue of the CTO intervention in chronic coronary syndrome. So in your experience, or have you reviewed any paper regarding the CTO, the symptomatic patient? What's the percentage of the CTO patient, average, symptomatic angina?
So I guess for decision CTO, the other thing that I felt I did not mention was actually a lot of their patients were asymptomatic. So if you're looking at percentage, I think in decision CTO, it was about 10 to 20% of patients who had no symptoms, or rather, if you look at it the other way, 80+% of patients had CTO. Had symptoms. But I think Euro CTO, they were much more strict. I think patients needed to have symptoms before they were recruited into this study.
And the other issue is the intervention procedure. In Singapore, right now, what's the general percentage of antegrade and retrograde approach?
I can't speak for all the centers in Singapore, but for my center as well as where I refer to, I would say the majority is still antegrade. I mean, like all CTO interventions, usually there's an algorithm in which we switch between antegrade and retrograde. So I think we do switch between antegrade and retrograde quite often, but I think that from the procedures that I've gone through, there's still higher success rate with the antegrade approach.
Okay, thank you. Dr. Prakoso, do you have question?
Yeah, thank you. That's a very, very good and very clear presentation. I would like to comment that, the CTO center, I think, is not well spread, but in Indonesia, for instance, only less than 50% PCI center can do about the CTO. And what is your comment on if we cannot do the procedure for CTO patients, especially in developing Asian countries? And are there any comment from you? Thank you.
Yeah, so I think the of course, other than just PCI, there's always a CABG option. But like I mentioned, not all CTOs are the same, and there are often quite simple and straightforward CTOs. So I think it's always worthwhile for interventionists to have an attempt at CTO PCI. And also, it's important to know your boundaries. So if you've never done a retrograde, definitely you shouldn't attempt a retrograde by yourself without a proctor. But simple antegrade with wire escalation, I think it's reasonable for all interventionists to attempt. And of course, if you fail at the initial attempt, at the end of the day, this is still a chronic coronary syndrome. This is not acute coronary syndrome, but you must rush in to do something. So go back to optimization of medical therapy. And if that still ultimately fails, then perhaps you have to refer to, depending on where you're from, a regional center with the necessary skill set to perform CTO PCI. Of course, there are also overseas proctors who come in. So we do have Japanese experts coming in over the last few years to help us with CTO procedures. So there's also, of course, another option for interventionists in the other countries.
Yes, and very great talk from the Dr. Kwa, and very impressive. Thank you for your presentation.
Thank you.
We'll move to the second speaker from Japan, Dr. Takehiro Hashikata.
Yes.
And Dr. Hashikata currently is assistant professor at cardiovascular medicine, Kitasato University, Tokyo, Japan. And Dr. Hashikata's talk, the topic is PCI additional or OMT alone for chronic coronary syndrome with left ventricular dysfunction, repercussions after revived and stage trials. And Dr. Hashikata, please.
Thank you for kind introduction to me, Dr. Professor Wang, and good afternoon, everyone. So I'm Takehiro Hashikata from Kitasato University, Japan. First of all, I'd like to express my sincere gratitude to everyone involved in Japan and other Asian countries for giving me such a great opportunity. Today, I'm sending you from Kanagai Prefecture, neighboring city of Tokyo. So this will be the last presentation in the program. So I suppose you all are already tired, but I hope you will listen to my talk to the end. So let's share the screen. Can you see that?
Yeah, it's clear.
Okay, all right. So today's title is a PCI additional or OMT alone for chronic coronary syndrome with left ventricular dysfunction. I'm going to talk about this topic and including the content of REVIVE trial presented in the ESC session this summer. This is my relationship to disclose. The indication of PCI additional for patients with chronic coronary syndrome, CCS, is getting tightening year by year, as you know. That because of the result of the COURAGE ischemia and other trials. However, this randomized clinical trial did not include the population with low ejection fraction and left main coronary artery stenosis. So the revascularization for CCS patients with LV dysfunction is still controversial. Actually, we historically recognize a hibernated or stand myocardium in CCS patient with LV dysfunction. I show the representative case, and almost all of you may have experienced such a case like this. This is a 76-year-old female who had a chronic renal failure due to the ADPKD, and she continued dialysis for 24 years. At the time, she presented with this dialysis syndrome with extremely low blood pressure and was referred to our hospital. Echocardiography showed the severe LV dysfunction, and coronary angiography showed 3 vessels disease with severe calcification. In addition, unfortunately, her left subclavian artery was occluded. The estimated mortality of CABG was extremely high at 63%. So we choose PCI after the health team discussion. We performed rotor atherectomy and DS implantation in the LAD using OCT. Immediately after the PCI procedure, she was free from this dialysis syndrome, and her BNP level gradually decreased, accompanied by ameliorating cardiac function. She was discharged 2 weeks after the procedure by foot. As we accumulate more and more experience like this, we instinctively believe that some hibernated myocardium can be saved and sometimes revived as myocardiums and be saved, and sometimes revived as, by the optimal revascularization. Also come to believe that it should lead to the better clinical outcomes. For the support data of saving hibernated myocardium by revascularization, I show you the result of the stitch extension trial published in 2016. Stitch extension trial is an open-label randomized control study. The primary object of this study is to evaluate the effect of CABZ in patients with severe ischemic cardiomyopathy, as ejection fraction was below 35%. According to the result of this study, CABZ plus OMT decreased the death from any cause and cardiovascular cause compared with OMT alone. The hazard ratio was 0.84. Although 5 years follow-up did not show the significant efficacy of CABZ, the stitch extension study supported a significant benefit of CABZ plus OMT over 10 years among CCS patients with severe cardiac dysfunction. This slide shows the subgroup analysis of death from any cause in the stitch trial. The benefit of CABZ was more pronounced in the non-Caucasian, including Asian people, and people with additional left ventricular reconstructions and the 3-vessel disease. Perhaps the greatest strength of CABZ lies in the concomitant left ventricular reconstruction. So when CABZ is amenable, we should positively discuss a need for additional ventricular reconstruction. And this trial also demonstrates the safety of CABZ in the more severe ischemic cardiomyopathy patient with ejection fraction below 28%. On the other hand, according to the difference in the efficacy between CABZ and PCI in patients with LV dysfunction, we are not sure so far because of a lack of randomized control studies. As you know, the syntax score indicates the anatomical complexity of the coronary artery, not the cardiac function. So we can only imagine them from sub-analysis of other RCT. In the COURAGE trial, which was a first-generation DS-era RCT, CABZ had a better clinical outcomes in patients with ejection fraction below 50%. This is one of the great valuable data reflected in the current national guidelines. Also, this is an Excel trial, which was secondary generation DS-era RCT now. Compared to CABZ, DS stenting showed a comparable primary endpoint in patients with ejection fraction below 50% and below 40%. However, the number of the population in this sub-analysis was too small to validate enough conclusions. So far, we have no some conclusion about the superiority or inferiority between the PCI and CABG additional in patients with LV dysfunction. Therefore, it was not known whether additional second generation DS implantation would have a valid outcomes. In such historical background, the revived BCS2 trial was started to run. This summer, Professor Perala opened the result of the revived BCS2 trial in the ESC Congress. Actually, from my small experience-based medicine, I had a little hope that PCI additional using second generation DES would be actually effective compared to OMT alone. Maybe not only me, but many interventionists might have the same hope. However, our little hope was dashed as no. According to the revived trial, multivessel PCI additional did not show a significant improvement in event-free survival and LV function among patients with severe ischemic cardiomyopathy compared with OMT alone. I'll show you more detail of what the revived trial entails. Revived BCS2 trial is a prospective multi-center open-label randomized trial involving patients with ischemic LV dysfunction conducted in the UK. Participant had an ejection fraction of 35% or less, and extensive coronary disease, and a demonstrable visibility in at least 4 dysfunctional myocardial segments amenable to the revascularization by PCI. Patients were excluded if they had AMI in the 4 weeks before the randomization, or acute heart failure, or sustained ventricular arrhythmias within 72 hours before randomization. The primary composite outcomes was a death from any cause or hospitalization for heart failure over minimum follow-up period of 24 months. Measuring the other secondary outcome as described. The patient characteristics in both groups are well balanced. In brief, elderly Caucasian male was a majority, and the mean B6 jeopardy score was 10, which means a severe coronary disease were dominantly included. So the mean ejection fraction was 27%. Approximately half of the patient had ICD, and 40% of the patient had TRTD at randomization. 70% of the patients were assessed for cardiac viability by MRI, and almost others were stress echo. Cardiac medication was here. At baseline, over 80% of patients received ACEI or ARB, and some shifted to ARNI according to the guideline renewal. Also, the beta blocker was prescribed to over 90% of the patients. That means the OMT situation in the present study was very good during the study period. The information on SGLT2 inhibitors were not described. This table shows the summary of the primary and secondary endpoints. As I mentioned, the primary outcome was comparable in both groups for a mean of 3.5 years. Of note, in the PCI group, procedural AMI was 38% of all AMI events. It suggests that the PCI procedure in this trial was, needless to say, the very high-risk one. And interestingly, PCI additional significantly decreased unplanned revascularization during the observation period. I will explain this content again later. Also, the measured bleeding at 1 year was less in the OMT group. This would be the impact of the drug antiplatelet therapy, regarding major secondary outcomes, though there is no significant difference between both groups, LV ejection fraction seems to be gradually improved in the PCI group. Otherwise, the quality of life improvement in the PCI group seems to be faster than OMT group. In any case, I think these results of major secondary outcomes are very difficult to interpret because they may have several large limitations. This is a conclusion about the revived BCS2 trial. PCI additional did not show the significant improvement in clinical heart endpoint and cardiac function compared to OMT alone in ischemic cardiomyopathy patients with LV dysfunction. This result may overturn the conventional paradigm of the recovering of hibernating myocardium after revascularization by PCI. So I'd like to start a discussion with you about this theme. Should we always avoid additional PCI in patients with CCS regardless of LV function? Looking back at the sub-analysis of the revived trial, we can see the efficacy of PCI additional and OMT alone were consistent regardless of patient and lesion characteristics, such as age and the BC score and the degree of LV ejection fraction and the diabetes, NOH class, the presence of atrial fibrillation, left main trunk lesion, and BNP level. It suggests that, as a whole, easy treatment can be chosen when we meet the patient who had a chronic coronary lesion as LV dysfunction. However, as I mentioned in the previous slide, planned revascularization had to be performed over 10% in the OMT group, while only 3% in the PCI group. It means what? Emergency PCI may have been available at any time in London, England, where this trial was being conducted. But what if it had been in another rural town in the UK? In Japan, Tokyo, or Kanagawa Prefecture, probably yes, we can do it. But how about another town in Japan? I'm not sure. Anyway, nobody knows whether it is possible to perform unplanned revascularization at any time and in any region. I think the indication for PCI should be determined based on the regional characteristics of each patient in your country. Additionally, I focused on the difference in ICD shock appearance between both groups. The incidence of at least one approximate ICD shock to terminate VT or VF was 40% in the OMT group and 6% in the PCI group. This difference is not small. This is significant in my view. Have you experienced receiving the ICD shock? Does it really not affect the quality of life? I don't think so. I think the PCI additional should be aggressively considered depending on the presence or history of ventricular arrhythmias. Now, similar to LC and the HA guidelines, the Japanese guideline recommends CABZ first in CCS patients with ejection fraction below 35%, according to the stitch extension trials and so on. So the needless to say, we have to consider the primary result of the ischemia and the revival trials seriously as well. And we should be more cautious than ever about the practice of additional PCI in particular. On the other hand, in the real clinical setting, we often encounter cases in which additional PCI must be chosen. For instance, ACS or acute heart failure, extremely high risk for CABZ, OMT resistance, including the history of ICD shock. And the last reason is very important for our business, That is a patient strong request. In the revival trial, PCI additional resulted in the high occurrence of procedural AMI. Just first of all, when we choose the additional PCI for some reasons, as I mentioned, we must focus on the safety of the procedure, especially in the low ejection fraction patient. Today, I'd like to introduce the CHIP intervention framework. This is an important concept in that situation. CHIP is an acronym for the complex high and indicated patient or complex high-risk interventional procedures. According to the CHIP framework, the complexity of PCI procedure basically consists of the three components: the patient comorbidities and the cardiac condition itself, including cardiac function, and the anatomical complexity of the target site. So the CHIP framework includes the optimal imaging or physiology-guided PCI and large bore access management and hemodynamics and ventricular support and complication management. Specifically, in the CHIP framework, the usage of FFR or IFR to determine the optimal indication of revascularization and the usage of OCT or IVUS during PCI is strongly recommended for better efficacy and safety, and should confirm the access route from the bilateral radial and the bilateral femoral artery to the heart before the procedure. And the optimized use of a closure device. Also, usage of procedural IABP or IMPER-CP support should be always considered if necessary. Finally, I show you a case under the CHIP intervention framework. The case was a 74-year-old male. He presented with acute heart failure due to the severe cardiac dysfunction with cerebral vessel disease. According to the STS score, the mortality of CABZ was 21%. So we choose a PCI to manage the heart failure situation after the heart team discussion. The transradial approach would be the first choice, and keep at least 1 or 2 femoral access for mechanical circulatory support. From the femoral artery, we introduce the IMPER-CP and perform PCI in the right coronary artery using IVUS. And 2 days later, keeping the IMPER support, we also conducted OCP-guided PCI in the lady, and there's a very stable vital signs. After the stage of PCI, oh, I'm sorry. I'm sorry. The angiography is oh. I'm sorry. Oh, the data was frozen. I'm sorry. Anyway, yeah, my slide is frozen. Sorry. So can you hear my words?
Hey, yes.
Okay.
We can hear you.
All right. Yeah. So I'll say the in conclusion, from the stitch and revival trials, CABZ should be the first choice for multiple suspicious patient with LV dysfunction, and PCI plus OMT show the comparable outcome to OMT alone. So this is just my opinion, but patient with LV dysfunction who have angina and a VT with history and ACS or an acute heart failure component may be aggressively considered for PCI. So the also indication for PCI should be determined by regional characteristic in your country. So the multivascular PCI for patients with LV dysfunction need to be conducted following the CHIP framework, which includes the optimal physiological and imaging assessment and large bore access management and approximate use of mechanical circulatory support. And finally, if you have a bit of a concern about the support, super high risk PCI, you should never hesitate to choose OMT alone. So I believe the PCI procedure is still an essential one in the field of ischemic heart disease, even in a chronic situation. To keep this great method development, I think we should continue to discuss among the heart team for determining the optimal management and continue to talk with each patient more for providing the best service. And I continue to shape our PCI skills and to save the patient life, and sometimes it leads to saving ourselves. Thank you for your attention. Thank you very much. I'm sorry for that.
Thank you for Dr. Hashikata's informative and excellent talk. And I think they also mentioned a very important trial, including the REVIVE and the STAGE trial. So I think the coronary artery disease patients with LV dysfunction is still an issue of debate. And what's the better treatment for these patients, KBG or PCI? But usually the patient is also some kind of reluctant to receive the surgical procedure, especially in the Asia Pacific countries. I think the same situation in Japan and Taiwan. So the interventional cardiologists also think about more invasively IABP supported or impeda supported, try to revascularize the coronary artery stenosis and try to improve LV function. And any questions from our audience? And one question for Dr. Hashikata. And in your hospital, how many experience the impeda supported PCI? Here now.
We have one case by month and in the support PCI case, and so the IVP support is as well. So we have 10 or 20 cases per year. Yes, but almost all cases was finished with under the very stable, by the science. I believe that under the mechanical circulatory support PCI is very safe compared to the high using high dose of dopamine or adrenaline using, I think.
Okay, thank you. Dr. Prakoso, please turn on your microphone.
Yeah, so it's very nice to have the presentation, Dr. Hashikata. So yeah, here in Indonesia, we have very low experience about using LVAD, for very severe LV dysfunction. But I think it's now is a challenging option to make another intervention for left ventricular dysfunction with chronic coronary disease. And is there any experience of having another option for very low LV dysfunction in your center? Perhaps like a transplant option. Thank you.
Thank you. Any other questions? If no questions, thanks for Dr. Hashikata excellent talk and well preparations. And if no question, I'll make a brief closing remarks. I think this session title Evolving Issues in Chronic Coronary Syndrome, and Dr. Allen reviewed the CTA to the risk assessment in symptomatic patients with suspected coronary artery disease, and also highlight the sensitivity, specificity, and also clinical use, and review the guideline. And Dr. Gajuro from Nepal also very good review on the high event risk identification, including many imaging modalities and including the exercise ECG. I think that's a very good review, including the MRI, X-rays, nuclear medicine testing, CTA, and also the PET scan. I think that's a very good review on the risk identification. And also the Dr. Pania Swaminathan reviewed the PCI additional or OMT alone for chronic coronary syndrome, and also bring us the good insights from the ischemia trial. I think very clear presentations to all the attendees. And Dr. Kwa from Singapore reviewed the law of CTO intervention. Usually this is an area of debate on the interventional cardiology. And Dr. Kwa has mentioned very important issue, how to help to our patients with the CTO intervention. Also briefly review the risk of CTO intervention. And finally, Dr. Hashikata from Japan, and also very good review the REVIVE and the STAGE trial in the chronic coronary syndrome with airway dysfunction, PCI additional or LMT alone. I think this is a very important issue for interventional cardiologists. And this session, I think every speakers have well prepared and also give the informative and also update knowledge to our attendees. I think this is a very good symposium. In here, I'll give thanks to the organizer, Professor Junli Lin. Professor Junli Lin is the past president of the Taiwan Society Cardiology, and he has organized the APSC crowd webinar. I think the Professor Lin's and also the personnel from the Taiwan Heart Foundation, including the Mr. Timothy Chang and also Mr. Cao Zhengdu, and all the personnel to maintain the webinar talk to the members of APSC. I think this kind of webinar is very convenient and also very helpful to the all cardiologists from the Asian Pacific area. We are close here, and everyone, if you are online, please turn on the video, and we'll screenshot for a record and also for memory. And Timothy, please help her to adjust all the photo screenshot. And Professor Lin, are you online?
Yes, I'm online.
Okay.
Yeah, no problem.
Okay.
Thank you.
Okay, thank you. So we are close here.
Thank you.
Thank you everyone.
Okay, bye-bye.
We will meet face to face in the near future.
Great
Thank
good
you.
section.
Thank you.
Thank you.
Thank
See
you.
you.